this is the 4th Advanced Pediatric Endocrine Symposium, which we are organizing. The first one in the form was actually started off in 2017. And since then, many of the faculty, all the guiders, everybody is the same. And we are continuing with the same team for quite a long time. It's been really a pleasure in that regards. Now, when we had initially, we were always thinking that pediatric endocrinology is a rare group of disorders, which are complicated, which are cumbersome in terms of workup and very expensive treatment. So people used to, in a way, shrug away from pediatric endocrinology, don't want to go into this field, and everybody was very scared, so to speak, about that. Now, when we thought about this, what we realized that there are 3 issues in any health problem: awareness, accessibility, and affordability. Now, everybody says these are not affordable, but we believe that awareness actually is the elephant in the house. And if we increase the awareness amongst the general public, amongst the physicians, we would be able to improvise the care. And this was the motto by which we established the pediatric endocrine group, and then we started the Growth Society working in that direction. Now, if you look at the pediatric endocrinology burden in India and the specialists who are available, what we see is that we would probably have a handful, maybe 100 will be the overall, maybe an overestimation also at the moment, but now with more fellows, the numbers will increase. So this still is a very, very small number for the burden of population for type 1 diabetes, growth hormone, thyroid, all those things. And pediatricians are approximately in much bigger numbers. So we need to really have a bridge in which things can improvise and connect between the two so that we can have a continual good quality care in everywhere. So currently pediatric endocrinology is focused and centered in few cities. Some cities like Bangalore will have maybe 20 people who are there, but then some whole states will not have people who are trained at all. So we need to have more wider exposure, and that's why it's very important on part of everybody. And it's responsibility of us pediatric endocrinologists, and ISPE has been working a lot in that to really spread the message of pediatric endocrinology. We have been doing a lot of programs right from 2011, and you can see many of the same people have been involved, and they have always been our inspirational force there. We started with our first program in 2011, and then since then there have been hundreds of programs which were done in terms of workshops, in terms of advanced courses, practical courses across the country, which we have been conducting. Now, this basically is the 3rd Advanced Pediatric Endocrinology Symposium. And from there, what we realize that if we keep on doing workshops, how much time can we spend? Like, it's not possible to do workshop everywhere. So we started off with social media in terms of YouTube platforms. And from there, a large number of people actually were able to access, and you don't need to be there all the time. They can access that. Then we started an on-site fellowship program, and we have got Chetan from the first batch, Neha from the second batch today, who are there. We until now had 11 fellows who are being under part of training. Then what we realized is that if you want to have a structured training, we need to have a web-based program. So we started with our MedEClasses platform, which provides a lot of information, started with books, and then to practically use that knowledge, mobile applications were developed. So we have got a lot of e-learning videos available on YouTube with huge number of views. This is something which is available covering entirety of pediatric endocrinology. We have got structured learning program under our learning.growsociety.in. We also offer a 2-year hybrid program for fellowship and a 1-year hybrid for diploma. We had got a lot of people who come to us every 6 months for a week. They learn the exam. So it's a very intense process. So we are going to have some of the announcements about the results of the fellowship program, the first one. We conduct a lot of online courses, pretty much 3 to 4 every month. So it's quite intense. We have got a number of publications which are there. And what we are going to launch today is the 2nd edition of our pediatric endocrinology protocols, which is a completely updated book about latest protocols for pediatricians, pediatric endocrinologists, and we'll be releasing this today. One major advantage we wanted to take was with regards to our application, because that will provide much easy access to use, because what you learn, if you don't use it immediately, you will forget and the errors will come in. And these applications were developed, and they are now become the most popular endocrinology application across the globe. And we have done a lot of publications regarding the growth interpreter, which allows practical interpretation of growth. We have got the obesity interpreter, which has been validated. We have got puberty interpreter, which allows interpretation of puberty, for thyroid, for DSD, and all of them have been presented and they are in publication in different places in that regards. Now, what we have done now is a very interesting thing, which is actually a combination of all that we have done. This is a bone age assisted interpretation of growth. So all the pediatrician would have to do is to put some basic data. It includes information like birth weight, sitting height. So all the rough things that we anyway write down and we measure, we just write the Tanner staging, we match it, we have the bone age interpretation. And as soon as this is done, it is using all the algorithms which are available. And based upon this algorithm, we will have a lot of information, data points will be available. So you will have specific charts, bone age interpretation, lot of parameters, and this will predict the likely diagnosis, most likely investigation. And we are validating this now. So this will be a very valuable tool for screening pediatric endocrine disorders. And hopefully, so this is how the result will look like. So you will have charts and you will have table which has got a lot of interpretation, and then we'll give you the final interpretation as to what is the likely diagnosis in that regards. We are coming up also with a personalized intelligent EMR, which is going to basically decide based upon specific conditions, give the inputs for every condition. And once you choose those conditions, you get the data, you will get an output which will guide in terms of evaluation, assessment. So only those which are relevant will come up on that drop-down menu. And based upon that, you will have a state-of-the-art evidence-based algorithm-driven approach which will come and analysis will come. This will provide information in the form of also a nutrition chart. So a 7-day meal plan will be there. So we had got, recently we had this on-site course in which we had got large number of people who had come from across the country, and we had around 200 patients who were seen over the last 3 days. And we had a very intense discussion which was there. So this Advanced Pediatric Endocrine Symposium, we're going to cover a lot of aspects of pediatric endocrinology. So we will try to cover 4 groups of disorders: hypogonadism, undescended testis, micropenis, and gynecomastia. Hopefully in the next 45 minutes. So I think Alapan will go in sync. We'll have to take Vande Bharat rather than a passenger train probably here. So hypogonadism, just to summarize, we all know that it's the Hypothalamic-Pituitary-Gonadal Axis. You've got the GnRH, which controls the gonadotrophins, which controls the testis. So if you have a problem in the hypothalamus, this is the hypogonadotropic hypogonadism, the LH levels are low. So LH is the best marker as far as the gonadal status is concerned. It is usually constitutional, but if you have other features like anosmia, hearing defect, think of a Kalaman syndrome, and you can have a functional problem. Testicular problem causes a high FSH level, so it's a hypergonadotropic hypogonadism, and that's how you will make a diagnosis. Remember that adrenals produce DHEAS, which is responsible for pubarchy. So if you have got no pubarchy and no gonadarchy, you will basically have a multiple pituitary hormone deficiency, constitutional delay of puberty and growth, or you have a scenario in which you have a problem in terms of the adrenal steroidogenic defect. If you have a normal pubarchy with delayed puberty, it is usually a problem of gonadarchy because of the hypogonadotropic hypogonadism, and that becomes important from that perspective. So hypogonadism can be physiological, which is usually self-limited. These will be shorter children who have got no pubic hair development, who will have a delayed bone age, or pathological, within which you will have hypergonadotropic, like Klinefelter, the classical example. Hypogonadotropic may be functional, or they may be permanent because of a multiple or isolated deficiency. We've all discussed in detail earlier on that. So if you have a short child with no pubarchy, think of 3 conditions: CDGP, functional, multiple pituitary hormone deficiency. If you have normal pubarchy, other conditions become important, and this becomes relevant from that perspective. So if you have a large testis with delayed puberty, this is very unusual. This can be hypothyroidism. If you have a small and soft testis, this is GnRH deficiency. If you have an intermediate testis, this is constitutional delay. And if you have a shorty testis, this is more like a Klinefelter. And of course, if you have no testis, think of anorchia as a possibility in that regards. So if you have pubarchy, if you have stalled puberty, normal growth, and micropenis, it is not CDGP. You're dealing with something else. And biochemically, if your inhibin B is low, GnRH stimulated LH is low, it is unlikely to be CDGP. So the first evaluation is to do gonadotrophin levels after the screening test. If they are high, do testosterone. If they are low, do a karyotype. If you have a high testo, then you have rare possibilities of 5-alpha reductase versus AIS. They will usually have hypospadia, so they will present with DSD usually. If you have low gonadotrophins and pointers of hypogonadotropic hypogonadism like micropenis, undescended testis, then you can think of a permanent HH. If not, and your testicular volume is low, inhibin B is low, this is permanent HH. While if testicular volume is more, inhibin B is more than 100, this is CDGP. And in between, you look at inhibin B. So basically, you're looking at LH, FSH, inhibin B, and testicular volume. This will give you the diagnosis in most cases in that regards. Treatment, basically, you use testosterone enanthate, which is an intramuscular injection. And usually we start with low dose and build up by around adult dose of 300 milligrams per week. And you can also have 1,000 milligram injection, which is to be given after the pubertal induction is done every 3 monthly. We don't usually use the gel or the oral preparations much. For CDGP, start with a low dose of 100 milligram monthly for 3 to 6 months and look for reversal. For permanent, you use again at 12 years and gradually build up the dose over 2 to 3 years. There is an option for fertility in hypogonadotropic hypogonadism. You can achieve fertility using LH and FSH. For hyper, it's only donor insemination. The chances are very, very minimal. So we'll start with the cases now, Dr. Alapan.
Thank you, sir. Our first case, a 14-year-old boy presented with delayed puberty. He has a similar history in his father. His height was on the shorter side. During his regarding his puberty, his testicle was prepubertal, volume of 3 ml, and a pubic hair of stage 1. So, Dr. Vikrant, sir, I would like to ask, how would you approach this case?
Well, as sir has already told, we have got a good family history that is present, and the child is short and who is having a testicular volume that is more than 1 ml, and pubic hair staging is 1 prepubertal. So it looks more like a constitutional sort of thing. So if we go by the algorithm, it looks like a constitutional delay of growth and puberty.
Yes, and this child had no pointers of hypogonadotropic hypogonadism, and inhibin level was on the higher side, 125.
That is the most important marker. Even before testosterone serum inhibin starts rising. So this is a pretty much pointer towards the fact that we are dealing with something constitutional.
So I think this is very, very nicely put in, that is, this is like a classical picture. So how will you now treat this case, Dr. Vikrant?
If the child is, since the child is more than 12 years, bone age of more than 12 years, we can give a push with testosterone 50 to 100 milligrams per monthly for 3 doses, and then we can look for the puberty to happen on its own. And most likely it will happen on its own once the push has been given.
Yes. So this is clearly no pubarchy, short child, testicular volume is high, high inhibin, give a course of androgens, and you are starting the engine, basically, you're pushing the engine.
Again, our case 2, a 15-year-old boy with delayed puberty, but this time the boy had a small phallic size at birth. Height is in the normal range in the 162 centimeter. But this time, in contrast to the previous one, this testis was 1 centimeter with a soft testis and a pubic hair of stage 3. So, Dr. Hemchand, sir, how would you like to approach this one?
Thank you. I think this case represents a total contrast to the previous case. If you see the case presented by Dr. Vikrant, he had a normal phallic size and the testicular volumes were 3 ml. But my patient, the phallic size is small at birth and the testicular volumes are just 1 ml. I have a petrol tank that is empty. He had a petrol tank that was in the reserve stage. I think that is the understanding. His is in the reserve stage, my tank is empty. And the second valuable clue is the dyssynchrony. In his case, the testicular volume and the pubic hair, both of them were dormant. But in my case, the pubic hair is behaving normally, but the testicular volume is dyssynergetically in a very quiescent stage. I think this is a classical case of hypogonadism. In the writing is in the wall on a clinical assessment.
Yes, sir. Again, there was no pointer suggestive of hypogonadotropic hypogonadism, but inhibin level was less this time, 20 picogram per ml. So
I think as per the algorithm, you have beautifully said, this child is moving himself towards a case of hypogonadotropic hypogonadism.
So how would you manage from here, Dr. Hemchand?
See, I think the management of this case should be, it's the story of the rabbit and the tortoise. You know, he has managed, Dr. Vikrant has managed it like a rabbit. He has given a stiff dose of androgens and he has stopped it. But I am like a tortoise. I have to go slow and steady because I have to mimic nature. I am dealing with a child with a disease. So I have to water the plant very gently. So I'll start on the lowest possible dose, which is 25 to 50 milligram IM, slowly increase by 25 to 50 milligram IM, and I will try to mimic what nature would have done. I would try to go slowly like a tortoise and mimic what nature would have done, slowly increase the size, slowly advance the secondary sexual characteristics, slowly improve the bone mineral density, and slowly advance the growth. But unfortunately, one thing which I am not able to do by this is push the testicular volumes upward. That is something which I cannot do by giving testosterone. So I would probably have to give them some amount of HCG at the time of fertility or as per the clinical protocol.
So we followed up this patient at 26 years regarding concern about the fertility. The testicular volume was again the 1 ml range, but this time we started HCG of 2000 international unit and FSH of 150 international unit.
So I think the fertility options would be there as discussed. So LH and FSH will be the one to go forward. Yeah.
And we started after starting, there was an increase in the testicular volume as well as the couple had conceived within the 12 months of age.
So this is a very important message that even the very bad cases of Kalaman syndrome, if you treat them well, they will be able to achieve fertility, but it will take 6 to 12 months of HCG and HMG. A big message here is that if it is a congenital form, always give FSH along with LH. Because if you do not give FSH, your HCG will increase intratesticular testosterone and it will destroy the germ cells because there is no protective Sertoli cells. So always combine both LH and FSH in that perspective. So this was a permanent HH. I think Dr. Hemchand clearly said if the prebubarki was there, inhibin B, and they have a fertility prospect.
Now the case 3, a 16-year-old boy with a pubertal concern. He had a pubertal onset at around 13 years, but the pubertal...
Yeah, Dr. Ahila, you wanted to say something? Recombinant FSH, there is very expensive and there is no benefit. Studies have shown, so HMG is pretty good enough. Because FSH, LH, the recombinant ones are very, very expensive.
But the puberty has stopped for 2 years. Now he had a testicular volume of 3 ml, soft, and a pubic hair of stage 3. His height was a normal range and he was diagnosed as CDGP. So Dr. Manoj sir, do you think the diagnosis is correct?
Thank you, Alapan, for the case. So we have discussed the previous 2 cases. We have seen in one case where it was a CDGP, where growth is delayed. And the second one that Dr. Hemchand has discussed, it was about the HH. So now this is the case of the stalled puberty. If we see the previously testicular volume was there, pubic hair was there, and after that something has happened that was not going towards the puberty. So it is a stalled puberty. Suppose one child is growing and it stopped growing, then something pathology is going on. So in this case, in the case of the stalled puberty, CDGP is not a diagnosis. We have to think about something pathology, like some tumor is sitting there or some Klinefelter syndrome is there. So we have to think in this perspective.
So this was very important. The LH-FSH was low and we found a large cranio sitting in there. So delayed puberty is not just about puberty. It can be a manifestation of a serious underlying disease if it's an acquired cause. Always be very, very worried if it's an acquired cause. Get an MRI done definitely. So organic pathology, again, as you said, neuroimaging is mandatory and normal height is against that.
Our case 4, a 15-year-old boy presented with delayed puberty. His testicular volume was 1 ml with no anosmia. The gonadotropin levels were in the lower side with normal screening test and MRI. We have given injection testosterone 100 milligram per month. So
on follow-up, what we found was that his testicular volume increased on follow-up. So is this different, Dr. Vikrant, now?
Yeah, obviously this case is different from the past because normally testosterone is not expected to increase the testicular volume. It can only increase the level of testosterone. So if this is increasing on its own after giving testosterone therapy, it is a strong pointer that we will be dealing with some reversible form of hypogonadotropic hypogonadism. As we have seen, hypogonadotropic hypogonadism is oligogenic in nature. It has a lot of redundancy, just 10 to 15% of the neurons are working, then still the pregnancy can progress. Still the puberty can progress. So this is a reversible form. So basically CDGP and hypogonadotropic hypogonadism are not different entities. They are just the two ends of a spectrum. Say if 30-40 are working, then after giving a push, they have to later on also they may falter. So
I think that's a very, very important point. So different from Dr. Hemchand's case, in which the TV remained low. It was like a permanent calamin, nothing is there. Here you have a chance of reversibility. Yes. So if your testicular volume increases, this is reversibility.
Our case 5, a 17-year-old boy presented with pubertal concern. Again, his puberty started around 12 years of age, but stopped for 3 years. But in contrast to the third case, the testis was 2 ml, farm 1. He had gynecomastia with a taller height of 182 centimeter.
And he had pubic hair as well. Yeah.
Yeah, so I think the writing is on the wall. This is a pathological cause. What are the red flag signs we can see? Presence of gynecomastia, presence of a small shorty testis, a firm testis, as I mentioned previously, tall stature. I think these are good enough clinical pointers to tell that we are dealing with an underlying syndromic condition for delayed puberty. So I think this puts that this child has a pathological cause. And if you see as per this algorithm, you really know that this child needs to be screened using gonadotrophin levels and the testosterone levels. So the gonadotrophins are like choke of a bike. The higher the gonadotrophin levels are and lower the testosterone levels are, it means that the gonads are moving more towards failure. So this is a gonadal failure response, and the cause of gonadal failure response has to be ascertained. So a karyotype analysis is done and a diagnosis is arrived at.
Dr. Rajat sir, I want to ask whether any surgical opinion regarding this gynecomastia.
Because they are very concerned with gynecomastia actually.
Adult patients who are above 15 years of age can be offered surgeries for gynecomastia, but the surgical treatment should be offered only after a diagnosis has been made and only after the medical treatment has been at least initiated or completed. So
I think that's a very, very important point, because often when we start with testosterone, the gynecomastia may worsen initially because of aromatization,
Right.
but after 2-3 years, it comes down. So this is something which is there. Yeah. So I think that's a very, very important point from that perspective. So tall stature, stalled puberty, shorty testis, this is Klinefelter syndrome. Gynecomastia is a common one. They don't have chances of fertility, are very, very poor.
Our next case, a 18-year-old boy presented with delayed puberty. He had a surgery for penoscrotal hypospadias with a penile length of 3.2 centimeter and pubic hair of stage 4. He had inguinal testis and gynecomastia, and his LH and FSH level was high. So Dr. Manoj sir, what is your next plan?
So here 18-year-old boy was there, and the delayed puberty. Here penoscrotal hypospadias is there with the micropenis, and pubic hair is normal, and with the higher level of the gonadotropin, and the test, if we see the testosterone level is very, very high. So we can assume that until there is no any issues, after that some problem is going on. So we have to do dihydrotestosterone. And can you elaborate what is the ratio? I think it is a high.
Yes, sir.
So
It was
basically, you've got a high
greater than 10.
testo and a low DHT.
Low DHT. So that it is a like Srikhandi syndrome that we have discussed yesterday. That some problem is going on from conversion of testosterone to DHT. So this is the case of the 5-alpha reductase deficiency.
This was okay. So it was more like a partial AIS. Testo was high and
DHT was high.
DHT was also high. So
Okay.
this was actually partial AIS. So there was some miscommunication. So this was actually a partial AIS. The message is, if you have delayed puberty with hypospadia, it's going beyond. So it can be 5-alpha definitely, And both of them you have to consider partial AIS versus 5-alpha reductase. Both are similar sort of a presentations, I would say. So what would be the recommendation about the penile size? Because they were very, very worried. Now, how effective are penile lengthening techniques, Dr. Rajat?
Most of the hypospadias cases respond well to stage surgeries. Penile lengthening, if there's a associated chordae that is with hypospadias where there's a bending of the penile tissue, so chordae correction does improve the penile length, but surgically there are not many procedures available to increase the penile length.
I think that's a big message, that they were going to different surgeons and they were trying that it will increase the size, and then we said, no, it's not going to help out in that regard.
So most of the hypospadias cases, the endpoint of the surgery is that the child should be able to stand and void properly. He should not wet his clothes or shoes. And the penile size, it should be a little above micropenis.
Yes.
There's not a set criteria that how much
Yes.
should be the penile size.
And partial AIS, usually if you give high dose testosterone, you may see some improvement. So it's going, this is a very challenging case. I think he was supposed to come in that case as well, but it's a difficult case, I would say. It's not as easy as, let's say, Kalaman is the easiest. Then you say Klinefelter, you can't achieve fertility. Here, both sexuality and fertility will be compromised. So we'll quickly go through to undescended testis, which is very common. 1 in 40 children will have cryptorchidism at birth. 70% will descend. 30% of these will remain permanent. More common in preterm babies. And usually you will see a temporal trend. The testicular descent will usually happen within the first 1 year. So if you do not have a descent by 1 year, it is usually permanent. Often beyond 4 months, the weight is not going to be much helpful. So sometimes between 4 months to 1 year, best to go ahead with a pediatric surgeon. Other messages, HCG is not recommended as a therapy. As I said, it can damage the germ cell. So do not give medical treatment unless you're thinking of hypogonadotropic hypogonadism, which is very rare to diagnose at that age. And then you give it along with HMG. That is a big message from there. So this is the manifestations from that regards. So the criteria basically are 4 months of age, no scrotal testis, look for scrotal growth, look for, sometimes the testis may be there. So you ask them to go into a tailor position, squatting position, cuff reflex, warm hand, palpate right from a 2-hand technique, starting from the superficial inguinal ring to scrotal sac, and try to bring down the testis. And you will be able to identify, because unnecessary referral should also not be done. And often Dr. Rajat will say that, okay, you will get a case as referred as undescended testis, and he will palpate and tell that nothing is required in that regards. So the approach is to exclude common causes. If you have palpable gonad with hypospadia, that's a different ball game. That's a DSD. You evaluate for that. We discussed, Dr. Manoj presented a wonderful one. If you have a palpable gonad, which is up there, but there is no hypospadia, send for surgery. Don't wait beyond 4 months, 12 months, definitely not. If you have no palpable gonad, now, if it is unilateral, of course, you have to do an exploration. That becomes very, very important. If it's bilateral, and you have a Mullerian structure, it becomes again XX-DST. So you have to evaluate. If it's absent, look at AMH and see whether it is anorchia versus abdominal testis. If you have abdominal testis, you explore. So look basically at the Mullerian structure, hypospadia, then AMH, and you will get the right diagnosis in that perspective. So you should refer any neonate with bilateral non-palpable testis, immediate evaluation, exclude XX-DST. You may miss the child because this may be CH. Bilateral non-palpable testis at a later presentation. If the AMH is detectable, send to the surgeon for abdominal exploration. Unilateral palpable / non-palpable testis after 4 months to 1 year for orchidopexy or laparoscopic evaluation. And if it's acquired also, send immediately. Sometimes you have an acquired ascent which may happen. If it's a palpable atrophic testis, you have to remove. I think that will be an important part to look at.
So our next case, a neonatal case of neonate presented with bilateral cryptorchidism, had a normal penile size. He was reassured. So Dr. Vikrant sir, do you think it was done right?
This is the most common thing that we should be wary of if the scrotal sacs are empty. So we may be dealing with some form of XXDSD like congenital adrenal hyperplasia, and that can be fatal if that is left on its own. So always we have to check for the Mullerian structures, whether they are present or not. If present, we should go for the 17 OHP levels. If more, then of course the diagnosis is CAH, and then it has to be treated accordingly with the cortisol and all those things.
So non-palpable gonad is a medical emergency. Do not avoid that.
Again, a 8-year-old boy, a obese boy with a left undescended testis. Dr. Rajat sir, what is your advice regarding this?
So the image, I would say it's more or less normal.
Yes.
Someone would say that it looks like a micropenis, but for a healthy 8-year-old boy with a lot of fatty tissue in the pubic area, I think the stretch penile length would be easily more than 3 centimeters.
Yes. And somebody said that the testis is not palpable,
So,
which often happens in obese children. Actually.
So that can happen. Sometimes there's a retractile testis, or the parents may have not noticed this for many years. So we start with a simple clinical examination. Mostly in 90% of the cases, I would say the testis would be palpable somewhere in the inguinal canal. And then we follow up with the ultrasound lower abdomen, which would localize the testis near superficial ring or deep ring, and then we can proceed with the required surgery.
I think very important, before we really label and refer through a surgical intervention, we should be very careful clinically.
Right.
That's a big message in that regard.
Next case, the 6-year-old boy presented again with a left undescended testis. He was undergone for orchidopexy, but his scrotal sac was well formed. So Manoj sir, what do you think about this case?
So here we have a 6-year-old boy who have an undescended testis, and the scrotal sac is very, very well preserved. So here Dr. Anurag sir has said that we do have a do proper examination, that it is a retractile testis or it is a true undescended testis. So suppose if we have a retractile testis, then if we do properly manipulation, then it can come into the scrotal sac. In that particular case, we don't have to go for the surgery. So this is the message, that before any conclusion, we have proper examination is must.
So if you bring down the testis to the scrotal sac, keep there for a minute, it will then remain there. That is the message there. Now, in this case, of course, retention test will give you a clue. Dr. Rajat, some people talk about doing a stitch or something so that it doesn't ascend. What is your opinion on retractile testis?
So mostly, I don't recommend a surgery for retractile testis. But mostly what we tell the parents is observe the child while he is sleeping. So if during sleeping you see that the testis is in the scrotum, then mostly we say that it doesn't need a surgery. And if the parents say that even while the child is sleeping, but most of the time they don't see the testis in the scrotum, and it is always suprascrotal.
Yeah.
And even if during a clinical examination the testis stays in the scrotum after stretching, keeping it there for a minute, but most of the normal hours of the day the testis is suprascrotal, yes, then sometimes you can offer a surgery.
Yeah.
But I don't think there's a very documentary evidence supporting the surgery, but
sure,
it can be done.
Sure. So
our next case, a 13-month-old boy with bilateral cryptorchidism. Dr. Hemchand sir, what would be your approach in this case?
I think this is definitely a child who has bilateral cryptorchidism is a red flag sign. So definitely we have to see whether we are looking at a 46XX DST, bilateral anorchia, or intra-abdominal testis. So I think, as you have beautifully put it below, an ultrasound should be done, an AMH should be measured, and see which direction this child is going to.
So now this child had no Mullerian structure, so DSD was ruled out. AMH was high, which means gonads are somewhere. So now what do we do, Dr. Rajat, in this case?
For any child with the bilateral non-palpable testis, the first procedure, you can go with simple ultrasound lower abdomen. If the testis is near the deep ring, mostly ultrasound will pick up a testis. If it is near the deep ring or near the urinary bladder, I think for any patient unilateral or even bilateral undescended non-palpable testis, the first thing that should be watched for is the pigmentation and texture of the scrotal skin. If the scrotal skin is pigmented and there are significant rugosities, then you can be nearly 100% sure the testis is somewhere in the abdomen. So if you, the second step is to do a MRI to specifically localize the testis, and for a bilateral non-palpable undescended testis, we go ahead with laparoscopic surgeries and follow up with a
I think
single,
this is very
spacer.
important because you want to remove them basically otherwise, or try to bring them down if possible.
For a 10-year-old child, I think directly removing the testis, even if the child is 10 years of age, has some sociological issues also. So mostly we said that we'll try to bring them down. Once the testis is brought down, at least the child can do a self-examination. And if in future some pathology develops, then we can do orchidectomy later also.
So AMH is the best marker of testicular tissue. Need for urgent evaluation.
Move on to the next case. A 14-year-old boy with right undescended testis. He had undergone orchidopexy 4 years ago. Now he has presented with testicular swelling with loss of testicular sensation. Dr. Vikrant sir, what is your opinion regarding this case?
Now, this is the red herring. Even after bringing the testis down, after performing a orchidopexy, the chances of getting it into malignancy, turning it malignant, that still remains. So, and the loss of testicular sensation alludes to the fact that we may be developing some tumor or intratesticular sort of malignancy.
So, Dr. Rajat, how would you approach this case? Like,
for unilateral testis with the suspicion of any malignancy, first we go ahead with endocrine evaluation, beta HCG, alpha fetoprotein. And if there's any direct or indirect sign indicating that there may be a possibility of any malignancy, you go to high inguinal orchidectomy.
And is there any role of FNAC in this setting?
Mostly, we don't.
I think
go
that's
for
very
FNAC.
important that FNAC should not be done
Don't go
in
for
this case
FNAC.
because it may cause more problems because testicular tissue may be exposed,
Right.
autoimmunity, everything will happen in that scenario. So testicular descent does not prevent the development of a tumor. Loss of sensation is the first sign. So self-examination is very, very important.
Our next case, a 14-year-old boy with a left undescended testis. This time the right testis was 8 ml, but the left one was small, 1 ml around. Dr. Rajat sir, I would like to ask your opinion regarding this.
So now for a 14-year-old boy with the very less volume left testis, I think the best surgical treatment that I would offer is that we would like to do orchidectomy on the left side and place a prosthesis.
Yes.
There are silicone prosthesis now available in various sizes. So mostly we wait till the patient has achieved puberty. So 14 years, maybe we can do it at the same time or maybe 2-3 years later.
Yes.
But that should be the best option, I think.
So the guidelines are now shifting towards probably what Dr. Rajat is saying exactly is that there's no point. This is like a time bomb there unnecessary. It's not doing anything. It's an atrophic testis. Best to remove. Like for abdominal gonads in a Y cell line in Turner's, we say remove the gonad. Something like that. It has a reasonable risk of malignancy. So orchidectomy should be gone. So unilateral cryptorchidism, there is no role of medical treatment. Avoid HCG. This is one big message you like to give. Surgical removal if it's late and atrophic. We'll quickly go to micropenis, which basically means that you have a normal male with the size below -2.5 standard deviation score with a normal genital appearance. So a normal median raphe, normal foreskin, and a urethral opening. Now, we all know that the major growth of penis happens within the antenatal period, and between 8 to 12 weeks is very crucial because that's the time the fusion happens. So problems before 12 weeks, which is testosterone synthetic defects or action defect, will cause hypospadias. Beyond 12 weeks, which is classically hypogonadotropic hypogonadism, you will have micropenis with normal genital appearance. After birth, you will gain around 1 to 1.2 centimeters in the first 1 year, and subsequently there is no growth till puberty. So if somebody has a small phallic size after 1 year, no point keeping on in that regard. If it's an early presentation, maybe wait and watch for some time. Otherwise, giving a course of therapy will have an important role because the increase in penile length is fixed. So if you are having short penile length at the onset of puberty, you will have a shorter towards the end of it as well. So definitely, if you have hypospadia, you are worried. And if you have micropenis, of course, you will see if it's at an early stage, you will wait and watch till 1 year, give treatment otherwise, and then go from there. There are now references available, so we'll not go much into details as to what criteria. So if it's less than 1.9 centimeters at birth, 3.1 at 1 year. Dr. Vaman has come up with the study, and Dr. Vijay was part of that study as well, which looked into that data from that perspective. So if a child is more than 5 years, less than 4 centimeters, this is what you need to be worried about from that regards.
So move on to our next case, a 8-year-old boy with a small phallic size. So Dr. Manoj sir, what would be your advice to
So yeah, if we appreciate in this picture, then it is a really case of the micropenis. So 8-year boy was there, and it was an obese child. So this is not a case of the DSD, but it is a case of the micropenis. So here proper examination is must, that either we are dealing with the micropenis or buried penis. So for the proper steps, what we have to do, we have to measure at the dorsal surface. It should be stretched penile length, and pubic ramus should be placed, and so we can exclude the excess fat, and excess skin should be removed. And after that, if it is in criteria of the micropenis, then we have to treat in this case. If it is not in micropenis, then it is because of the obesity, or it is because of the buried penis.
So this is the most common presentation of buried penis. So don't unnecessarily work up in that regards.
our next case? A 3-day-old boy presented with a micropenis stretched penile length of 1.8 centimeter with a testicular volume of 2 ml, and he was discharged and again presented with seizures-like manifestation. So, Dr. Vikrant sir, I would like to ask you about the opinion regarding this case.
Micropenis, any midline defect, they may be pointed out towards something that is related to pituitary, some multiple pituitary hormone deficiency sort of situation can be, the child may be inhabiting that. So the patient was discharged. So it was not a good decision to discharge the patient before getting him worked up properly. So as you have nicely put it down, the sodium is pretty much less, so it may be hyponatremia because of some cortisol deficiency.
He had hyponatremia, hypoglycemia, so this looked like a multiple pituitary hormone deficiency.
And that would be fatal if not properly treated.
So anybody with micropenis, this is again a medical emergency, especially in the neonatal period. You do urgent glucose and that.
Our next case, 3-month-old boy presented with micropenis and hernia. Electrolyte levels were done, which was sodium was mildly decreased to 130 millimole per liter. Potassium was slightly raised, 5.8 millimole per liter. He has a microcephaly of head circumference around 32 centimeter and a prominent facial features like upturned ears, lucid ears, and also he had micropenis-like situation. So, Dr. Hemchand sir, what would be your opinion?
I think you have given the diagnosis, as you may elicit the history, the presence of head circumference that is below 2 standard deviations. You have a prominent upturned ears, and you have micropenis, and you have dyselectrolytemia. All this is pointing towards an underlying genetic condition, which is quite known to be associated with cortisol synthetic defects. So low cholesterol, low cortisol, microcephaly, limb anomalies, all this points out to a genetic disorder, Smith-Lemli-Opitz Syndrome. I think this has to be kept in mind in this condition.
So very careful clinical evaluation becomes very, very important.
Again, a 3-month-old boy with a small phallic size. SPL was 1.6 centimeter. Testis was bilaterally palpable or 2 ml. LH FSH level was on the lower side. So, sir, what is your plan, Dr. Manoj sir?
So this is the case of the 3-month-old boy who came with the stretched penile length of 1.6 centimeter. So here we have to and LH FSH. At this age, the boy should be in the mini puberty. If LH FSH is really low at this stage, then either we are dealing with the multiple pituitary deficiency, or either we are dealing with the hypogonadotropic hypogonadism. So we need to work up for that, and we need to give testosterone if its size is not improved after that.
So we followed up. There was no increase in the penile size, and testosterone was given in the 3-cycle 25 milligram. In the 14 years, the boy presented with anosmia and delayed puberty.
Yeah, so now really the pointer has came. Like previously, the picture of the child was not in puberty, mini puberty, and the micropenis was there. Now the anosmia was there. So now it is clearly pointing towards that we are dealing with the hypogonadotropic hypogonadism. So we have to induce the puberty, as Dr. Hemchand has said.
So very importantly, most patients with isolated micropenis will improve after a course of testosterone, but always call them back at 12 to 14 years. There will be 10-15% who may have hypogonadotropic hypogonadism, who will require support subsequently. So this is something which is very, very important. Yes. Yeah, we discussed that in the initial cases about the TV and that level. Now we'll go quickly over to the last part of our discussion on gynecomastia, which is also a very common presentation in adolescence. So gynecomastia usually is physiological, which could be neonatal or it could be pubertal. Pathological causes could be either because of androgen deficiency, estrogen excess, or systemic causes. Now, when you have hypogonadotropic hypogonadism, gynecomastia is milder. Klinefelter hypergonadotropic hypogonadism or partial AIS or 5-alpha, partial AIS, you will have much bigger gynecomastia, which is there. Testicular tumor are rare, but you need to be aware about that. You can have HCG and adrenal tumors as well. And importantly, hyperprolactinemia does not cause gynecomastia directly. It causes gynecomastia through hypogonadism. So if you have a borderline prolactin, don't get too worried about that in that regards. So when you say gynecomastia, it's a benign symmetrical development and it's a fibrous concentric tissue. Always exclude lipomastia. So palpate the breast tissue using a thumb and finger, approximate if it's coming closer without resistance. This is basically a lipomastia. Otherwise, it's a gynecomastia. So this is usually a bilateral process. Tenderness again is common in this age group, which will improve. So if you have an onset during puberty with pubertal stage 3 and 4, testicular volume 8 to 10, diameter is not too much. This is physiological. If it's before pubertal onset, after pubertal onset, if it's much bigger, diameter is much more, think of a possibility of a pathological cause, which will be, you have to worry about in that setting. So when you want to evaluate, you see whether it's really requiring evaluation, pre or post pubertal onset and a big size. In that case, if it's not there, no evaluation. If it's there, look for common causes like drugs, liver, thyroid, renal disease. If there is there, you manage them. Otherwise, you do a testosterone. If it's low, it could be hypo or hypergonadotropic hypogonadism. If testosterone is high and your LH is high, this is partial AIS, or low, it could be a testicular tumor. And if testosterone is normal, then you look at HCG tumor, which is rare. So most cases, you may need no evaluation. In certain cases, you will need testosterone and LH. Rarely HCG will be required in this scenario.
So next case of 15-year-old boy presented with gynecomastia. It was noted 1 year ago. It was a non-tender swelling with the testicular volume was around 4 ml. So Dr. Rajat sir.
So this is a common presentation that we get during puberty.
So mostly during puberty, some mild gynecomastia testicular volume is less than normal. So I don't think any intervention is needed in this.
So
patient.
this is most likely a lipomastia, first of all. And then even if it's gynecomastia, this will be physiological. So you palpate the tissue and no workup is required here.
Move on to the next case. A 14-year-old boy presented with gynecomastia. It was noted 6 months ago. It was a tender swelling. The testicular volume is around 4 ml. Dr. Hemchand sir, I would like to ask you about this case.
I think this is a child with gynecomastia, probably pubertal, but it is symptomatic. So I think this symptomatic child, I think the onus is on us to provide relief for this child. So I think a testicular volume of 4 ml suggests that this child is having the onset of puberty and 14 years is the age and he's symptomatic. So there is a mild increase in the estrogen levels, which is probably responsible for this. So a trial of pharmacotherapy can be considered after explaining the pros and cons to the disease.
Or you can do local measures. So it's up to the physician, I think, what they're comfortable. So reassurance may also be a good one. So physiological gynecomastia is when you have near the puberty.
Next case, 18-year-old boy presented with gynecomastia. It was noted 3 years ago. It was a non-tender gynecomastia. Testicular volume is around 20 ml. Dr. Vikrant sir, what would be the approach in this case?
Now this is a red flag. 3 years ago it started and now still it is persisting after 18 years of age, and that too with the testicular volume of 20 ml. So I should be a bit wary about it. I will try to probe it further. What needs to be done.
So we need to evaluate for the cause and
For the
candidate
cause
for
and-
the definitive treatment in this regard. So if you have a pre or post pubertal onset, large size persistent, this is a bad sign. You need to evaluate.
Our next case, 17-year-old boy with breast enlargement. It was a recent onset and a rapid onset. Testosterone level was sky high, 920 nanogram per ml. So Dr. Manoj sir, how would you like to go ahead with this case?
So here, child, I think they has a 17-year-old boy and who has a breast development which was a rapid. So here it was if something is going very, very rapidly, then we have to be worried. And testosterone level is very, very high here, and LH is low. So can you, yeah. And there was a testicular lump and the leading cell tumor. So LH is suppressed and there is a high production of the testosterone. So here we have to think about the tumor. Either there is a toxicosis or subtumor is sitting there.
So mostly you will be here, no evaluation required. We discuss cases where you may have just lipomastia. Otherwise, you will have to consider testosterone low, then Klinefelter. Otherwise, this is the tumor. Leydig cell tumor will be there. Rapid progression, virilization, high testo, low LH. Dr. Rajat, what is the management of these tumors?
For all testicular tumors, the first surgery after proving the diagnosis is a high inguinal orchidectomy. After high inguinal orchidectomy, the patient is advised to continue with self-examination of the opposite testis, because there have been cases where the patient who has had a testicular tumor in one side may have a tumor on the opposite side also. Biopsy we don't do.
Yes. Yeah. So I think that's very, very relevant talk, that you just have to look at the other side also, whether you have a bilateral, because you may have a predisposition syndrome which may cause that.